I'm really delighted to be here. Thank you so much for inviting me. And the earlier talks have just been absolutely fabulous, let me say. So I'm really going to talk about prevention, and I'm advancing the next slide here. I'm from the Black Dog Institute in Australia, Sydney, pretty close to the beach, and it's what we do there essentially, or what we've been doing for the last 15 years really, has been developing apps and platforms for digital mental health care, and also engaging with science and research around those. And I think from what I've heard today, it's really maybe a nice comparison to what the earlier speakers have talked about. So also I put an emphasis on prevention, and I'm not quite sure if that was the right thing to do, but I was thinking that that was something that we did want to talk about. So prevention as opposed to treatment for mental health using digital technologies, of course, is an amazing idea because of the potential for prevention and going at scale to reach the whole population. So we find in Australia that mental health funding is underdone compared to the burden of disability. But if you actually look at the amount of money that's spent on prevention, it's 1% of the mental health budget, which is really not a very good use, we don't think, from a public health point of view, of how we should be spending dollars, because ultimately I think the evidence is pretty much emerging that you can prevent certain sorts of mental health problems. Now, investment in health tech in Australia is relatively strong, but compared to the United States, we're a small country and we really don't have it. So a lot of what's happening, I think, it is happening internationally, although I think Australia has tended to lead in some areas of the development of mental health apps. So what does the digital mental health landscape look like from my perspective anyway? So there's a massive number of industry, academic and other players with great interest and lots of spinning out, very busy area. There seems to be these two universal streams of work, the academic non-impactful apps and platforms versus the slick, useful, community-supported platforms. And I think hearing about Talkspace and what's being done in America from a mental health consumer perspective, I think you guys are doing fantastic stuff because you're actually combining the evaluation and the data and putting that into apps and learning as you go. And I think that has not been happening as much, and you're obviously early leaders in that. Of course, in Australia, there's lots of barriers around privacy, trust, regulation, standards. And in the app world, there's much more interest in treatment than prevention. But of course, COVID, as you both pointed out, has changed the conversation around digital. And I think it's actually changed the level of trust that we have and are seeing within our communities here. So the last 15 years or so, we've been trying to develop different services across, I would say, 4 main forms. The first are standalone apps. The second are platforms that screen, offer resources and monitor, for example, students in schools, and I'll show you that. We've moved into multi-platform services from automated to face-to-face care, and this is a new app that we've developed for frontline workers during COVID that I'll try and explain. And finally, I think the way to go is the ecosystems that have been talked about already from earlier speakers that link and pull together around collaborative care. So the idea ultimately is to provide the sorts of services that people want, as Teresa said, but also if you are going to go into care, it should be collaborative care because we know that that's the sort of best outcome type care in mental health. The model of collaborative care rarely gets done, and maybe we can do it in the digital space. So I'd also add that as a medical research institute, Black Dog undertakes extensive research around this, and I'm just going to talk about 2 little studies that we're doing at the moment to try and push the dial or bend the curve on mental health detection and delivery. So this is just a slide showing what we do in the teenage to adolescent age group, the sort of products that we actually have. Well, they're really more research projects than products, but you can see that what we're trying to do is develop various different sorts of apps and interventions that are useful to young people. And we also are developing lots of apps and other things for adults. So particularly in the workplace where we see as a public health response, we can actually get in and help people within the workplace to, of course, reduce presenteeism and increase productivity, but also just to increase the world and making it a mentally healthier place. I'm going to talk about some of these apps in a moment. So let's start with the first category that I talked about, which was standalone apps. We're talking about working apps in suicide prevention. So this is a new idea, really, apps, I think, in suicide prevention. Well, that's not true. We have safety plan type apps and so on. But what we're trying to do in these first two here is actually take a type of therapy program and put it into an app so a person can use it directly. The first one is called Lifeboy, and it's designed for young kids, and we only started trialling this during COVID. Within 2 days, we had 426 young people sign up to be part of this app to evaluate its effectiveness, and they were all screened because they had levels of suicide ideation. So it's quite amazing what COVID's done for research in a way in digital, because there's a lot of people interested in participating, but it also reflects, of course, the human problem that we are having at the moment with COVID and the hopelessness and distress that it's causing in young people. The second is an app called Betterside, which is based actually on a program called Living with Deadly Thoughts that we developed with, we took from the Dutch people, essentially, who had done some randomized controlled trials on this. Breccia van Spijker was the main person. And now we're turning it into an app that delivers a mixture of CBT, DBT, and other things through an app. And it's being worked up at the moment to make it implementable. And in terms of the equity thing, I think we're very keen at Black Dog to make sure that we do develop things that are helpful to people. And this is Healthy Mind, which is essentially a CBT app for people with intellectual disability who, basically using CBT to help them manage their mental health problems. So I won't go into this in much detail, but our model is let's develop these apps in conjunction with the people for whom they're designed and test them like you would a medication or any other thing, compared to either a placebo or sometimes a wait list, depending on the circumstances. This is iBobbly. I'll talk about that in a second. This is a new one called Sleep Ninja, which is sleep difficulties for young people. We have WeClick, which is a relationships-focused smart app designed to reduce mental health problems amongst adolescents. So it has these 4 characters, and they all have relationship problems, and basically it's trying to teach CBT to them using these characters as a way of describing their lives or reflecting their lives and their doubts and their fears and all the rest of it. So it's really quite a nice little app designed by Bridie Day and a number of other people. But what we've done is one trial which has shown that it does reduce anxiety and it increases help seeking in a randomized controlled trial. This is the one I was talking about, iBobbly, before. It delivers acceptance commitment therapy to young Indigenous Australians, and these are the data from the pre-trial or a randomized controlled trial, which basically showed that we did get significant effects on distress and depression, but not suicide ideation. But it was a quite small trial, but you can actually see that this particular app shifted groups of people from severe to mild as a result of using it. And it was a really nice trial in trying to reach Indigenous populations in Australia and try and deliver something that they wanted, they recognised, and they helped co-design. Now, that's the sort of standalone app type stuff. And then there's these, what we might call trying to integrate into health systems type work. And our major focus here has been in schools. Now, I'm not going to ask you to have a look at that particular diagram. I'm sorry, it's too much. But essentially we have something called Smooth Sailing, which is a screen. It goes into schools, the kids do it, it screens them for mental health difficulties, for use of drug and alcohol and so on. And the information is played back to the school counsellor and also played back to the kid and also to the parent. So these are kind of young kids who do this, and we found enormous uptake in schools, believe it or not. Most parents do want to see that if their kids are having problems, somebody is looking after them. Of course, the school counsellors, when we first started this, thought, no, this is going to lead us to too many kids coming forth with mental health problems. But actually, with the training that we provided to the school counsellors and to the whole school, I think this was a good example of screening plus monitoring plus delivery of a range of internet interventions all within the same platform. Some of the research data that's available on that platform. Okay, so sorry if this is such a rush. I'm now moving from these kind of step care online integration to education services or healthcare services into what we're calling multi-platform services for automated, that lead from automated help through to face-to-face care. We had some funding provided to us by the government of Australia for frontline workers who, as we know, are experiencing extreme distress and what is now being called burnout as a result of the increase in number of people who are dying from COVID and the requirements that they were working in hospitals, couldn't be with family, were scared that they were going to bring COVID home to their families and so on. You know, they're really the frontline people who are working every day. So we developed what we thought was what they wanted, which was an app that went from app and ultimately allows the person to go into seeing one of the black dogs into our clinic, whether by video or face-to-face, to see our psychiatrists, psychologists and other teams that we have at Black Dog, and where we deal with normal kind of clinical practice, if you like, in depression. It was free. It was trying to meet the needs of confidentiality, which of course we know is a real problem in these kind of situations with health professionals who won't even talk about what's going on, understandably, and who may need to get a lot of help from their forums and other things. But essentially this was something called 10. It's available in the App Store if you want to have a look at it, where we do test and track features so people can test themselves, see where their mental health is. They can engage with online programs that have efficacy, which are automated, or they can link in the network side to forums. They can find psychiatrists. They can reach various different organisations as part of a network, and they, if you like, find their way through to that. But during the course of it, there's a button they can press as well that says, I want to talk to somebody, and basically, yeah, they can actually get to talk to people. The interesting thing about this, and I won't go on about it too much, is that we found that instead of the app being the most popular form, a website was better, surprisingly. It went against all our grain. And the other thing is that, not really shown here, but that we had 22,000 people come and use the app within that particular period of time, but only 3 people actually went through to the clinic. And I think what we've done now is we're repivoting that app in a way that is a better approximation to what people actually want, what we've learned in the course of the last 6 months, but also what's happened to the mental health profession during that time. So we're looking for our next change in that. But that probably to us was the first time we went actually from digital out there all the way through to potentially providing proper clinical services, whether they were via blended care, digital care or face-to-face. And so it was quite an interesting perspective for us to learn how to do that within a very short period of time. And I know I've been talking too long, probably. If you can tell me to be quiet, I'm quite happy to do that. I just wanted to throw in that we also do research around this kind of, if you like, trying to bend the curve on what's happening in terms of digital. And to describe our first project is the Future Proofing Project, which is a study of 20,000 young people that we're following over 5 years, and half of them are being randomized to a prevention intervention and half of them become really our cohort study. And the idea here is that we're also going to we are using digital phenotyping through a mobile app in order to try and pick up those signals that Neil talked about and others talk about in how are we really able to tell from an individual level whether somebody's at risk or whether they're developing an at-risk profile. And we at the moment are collecting passive data on location, device usage, typing. We've got information on movement. We collect voice samples. We do cognition, and we also do self-report surveys. And we do it all through one app, which is downloaded onto the young person's phone, and we've already intervened or done the baseline anyway for this 2,500 young people, probably most of it in the last few weeks as schools are beginning to open in Australia. And the idea is to say, can we predict the development of mental health problems for young people over time? And the intervention is Sally Marx's Sparks, which we've modified for use on a mobile phone and to be a preventative intervention rather than a treatment. And we're using our Instill digital phenotyping platform to collect this data. Now, we've learned a lot so far, and it's all about engagement, which is something that other people have talked about already today. And it's also about how hard it really is to get digital data when you're doing this in the wild with young people and in the community. But we are succeeding so far, but the number and amount of digital data we're getting is perhaps not as much as we hope. And the second thing we're doing is AI, which I won't go very much into, but essentially our digital platform now has modules of interventions that can be delivered up to people. And we're using adaptive trials now rather than long randomized controlled trials to quickly learn, test and fail, and also to build into it AI, which reiteratively allows us to allocate people to different treatment conditions. I won't go into this too much either, but essentially that we're doing quick mini trials rather than long randomized controlled trials using digital. Everything is digital. And we're hoping to see if AI can really help us in delivering the right sorts of treatment to, in this case, university students for psychological distress. The lessons we learned so from Optimise is that we think it's a good idea. We think we'll be able to develop up, because of our digital expertise, lots of these different sorts of digital interventions where we can't choose which one's going to be most effective for whom. Basically, we're just trying to make sure that we can learn something about the individual characteristics of people and what sort of psychological digital interventions work best for them. So over 15 years, we've been doing preventative and treatment digital interventions. There's this huge continuum. Everything has a place. We are really at a tipping point, I think, in where we're going with digital, and COVID has been an accelerant, as Neil pointed out, and we're looking forward to the next phase of digital intervention. So thank you very much, and sorry about the problems at the beginning. Thanks, Tara.
Thank you so much. So I think I'm echoing back. Is that happening for everybody? Yeah, great. Thanks all. I think it was a great panel. Thank you to all the speakers. We have a short break, and we will be back in about 10 minutes for the panel discussion. And I think maybe we'll hold on questions. I certainly have several questions, but I'm going to hold on to them till for the panel. If you would like those, folks, you can put your questions into the Q&A box, and we'll, so that they're there when we start the